Thank you, sir. Thank you for the nice introduction. And I would be presenting various videos on different kinds of surgical procedures that we can try for subluxation in children. And I must acknowledge the first subluxation case. What I did was after a lot of hesitation, because these children, if you attempt a surgery, literature shows that chances of retinal detachment is higher and complications related to surgery is higher. But first case what I faced was a child with a counting finger vision and other eye 660. I had no other option. And I had a good teacher. The first case I did was under Dr. Ajay Paul, and I've been doing many such cases after that for the next 3 to 4 years, and I have a compilation of videos of that. All of us know that it is a progressive disease, so when to operate I have already covered. If a child is having 6/12 vision, suppose with subluxated lens and a high refractive error, we can wait for some time. Ideal age will be, whatever you can delay, 8 to 9 years, 10 years, if you can delay it till that time. And the various procedures that is done in this. So let's go with the first one. In this you can see the pupil is not fully dilated. So first intracameral oculin or xylocaine was used. Chondroitin sulfate is very important, very handy in these cases because it prevents vitreous prolapse from the subluxated side. And then we initiate the rexis. After initial initiation, we had to pull the lens towards the center, and then CTR was implanted. At this stage, you get some stability of the bag. Then we did a cortical aspiration and IOL implantation, a single piece hydrophobic lens, which is the easiest to implant. Now what you notice at the end of this, that we have ended with a very small rexis. This is the rexis margin what we are seeing. So that had to be enlarged. So we made a small nick in the rexis margin and enlarged the capsular rexis to a respectable size. And finally the Sioni segment, as was shown in previous videos, it was introduced in the bag and pulled out, and the bag was fixed. And most of these children, they have, I would say 100% of them had improvement of vision almost to the extent of 6/12 and 6/9. One important tip here is most of the times you will end up with a small rexis because you don't want the rexis to run away. So you should have the microrexis forceps, the micro scissors, which will help in enlarging the small rexis. In this case, I had to make multiple nicks. Whenever you are making a nick, it is important that you complete that. Multiple nicks is to Delhi, and he is still maintaining 6/9 good vision, underwent yak caps day before yesterday. Then I modified my technique after this experience. I decided to use Sioni ring because initially I was hesitant to use Sioni ring because when you are rotating the Sioni ring, that causes more stress on the zonules. But I decided to give it a try, and it was much easier when compared to the earlier procedures what we were doing. Same, most of it was same, but the ring was implanted before cortical aspiration. Now you see the ring is going, and initially you may face some resistance at the zonules. You have to be gentle so that it doesn't pierce the zonular bag. The ring is inserted. You have to dial it in position so that it is towards the eyelet is towards the subluxated side. And when introducing 26 gauge, you could make out I was supporting it with a spatula so that it doesn't pierce the capsule. Again, supporting it with a spatula, brought it inside, and anchored it. And once you have anchored the bag, then cortical aspiration also becomes much easier because the bag is stable. The final knot was not given, but anchoring was done. This is what I used to fear initially, but it doesn't make much of difference. You can dial it quite comfortably. Then the lens was implanted. Now, the next case, I decided to do something different. In this, after completing the rexes, as you can see, subluxation is also huge, almost 270 degree subluxation in this patient. So, after initial rexes, the capsular hooks were used to pull the lens in the center, and the rexes was completed after that. Then the difference is that I decided to do cortical aspiration first before implanting the Sioni ring. So when the ring is going inside the bag, now what you will notice, now it's fine, it's progressing well. The leading edge of the ring is still in the bag, but from this side, if you notice, it's coming out of the bag. And slowly when I'm advancing with the ring, that progresses, and now it's the whole ring is out of the bag. We are in a situation in which a large ring and a small bag inside the eye, and almost after 15 minutes of maneuvering, I was almost sure that I will have to give it up now, but then I decided to dial it in the reverse direction, and luckily for me, this time it went, and 2 Sinskey hook was used. And the other side was gently pulled inside the bag. And one important thing is Sioni ring comes as a right-sided or left-sided. So you have to be sure whether you have to use a right-sided Sioni ring or a left-sided Sioni ring. Single piece lens in the bag. And you are fixing it on the one side only. So over the years, what will happen, since it is a progressive disease, the other side will give way. So we have to be prepared what has to be done at that point of time. This video will show a very small procedure. It takes hardly 10 to 15 minutes. Just a small anchoring suture through the fibrous bag at the haptic-optic junction that is brought out through the scleral pocket. One goes behind, another goes in front. And you suture it, the lens is back in the center. So this will help. This is long term. Many critics of these procedures will tell, why are you doing it on one side when it is a progressive disease? It should be done. But fixing it on both sides is again very difficult when one side you don't have space. So this is the solution to this. Thank you so much.